It's go time. Now, I'm in two minds really because we should play the opening sequence, shouldn't we? Because it's like our favorite thing and probably everyone else's favorite thing. But then when I play it, I know you're dancing, which upsets my soul because it's that bad.
What?
Your moves.
No, it just upsets you that I'm happy.
Yeah, absolutely. Yeah, it's so unfamiliar. Right. So
Chewy and Jim, chatting along on their old pod. Chewy and Jim, chatting along on their old pod feed. Chewy and Jim, HR keeps them afloat. We go to play and have a look with Chewy's gags, Jim's dashing looks. The world wishes their views were tame, so Chewy and Jim just take the blame. Chewy and Jim, just get on with the show.
just get on with the show, and then it lingers for several more seconds than it needs to. Did I tell you about my mum having a bit of beef with the theme tune? Did I tell you about this?
No.
She said, why does it only reference Jim's dashing looks?
Well, yeah. Well, there's a very obvious reason for that.
She was fuming. Obviously, big dispute from that. And also, I think we need captions on that theme tune because it's not until it says "get on with the show." I don't think you can even understand what it says.
I think that's part of its charm.
You were caught dancing there, and then I couldn't carry it on as normal. So we need to work on that.
Fair play, anybody who made it through the second attempt.
Extra double, the extra one. Press skip. So yeah, this is Chewy and Jim. We still, find it amusing that you enjoy this. We obviously have ample opportunity to talk about our views in other formats, and we do so on Chewing It Over, Rheumatology Physio. We get a chance to do that, but we rarely get a chance to broadcast our back and forth we have with each other or what grinds each other's gears, usually each other. We usually annoy each other. We've had to censor those talks. If it was just us having a major disputes between ourselves, then that would be hilarious. I thought one of the things we should tell the listeners before we get stuck into the meat of the topic, because we were allowed to be a bit autobiographical and niche with this content amongst above all others, is that we had a Chewy versus Jim that we will be able to show them at some point soon, won't we? So I was going to pull up some pictures of that. Because, if in fact, by me not being able to pull the pictures up, then that's a really boring point I'm making. Because I was going to show them some of the images from the skirmish that we got into, especially the ones where I'm actually celebrating despite losing. I enjoyed that bit. And just in the photo sequence does not tell the fair story just because you were that out of puff. I mounted you. So yeah, without pictures, that's not a funny story. And for some reason, I think they're too high resolution for this footage. But yeah, you've got that to look forward to. We had a round of Chewy versus Jim, including some physical challenges. And yeah, Jim just fundamentally chose the right partner for the piggyback wheelbarrow race. Is clearly the only way in which he managed to well, you'll see the photo finish, which is then to be disputed at a later date. I was struggling I'm so at peace with the world of MSK, Jim, that I was struggling for something to whinge about, to be honest. Partly that could be because I'm not I've not been as in touch with it as you. We are in a building phase. We are kind of coming up and scheming all sorts of projects. So I've not been as close to it. So there's been less to annoy me. But lo and behold, as soon as I thought you might say the same and say, yeah, we can have a really upbeat and peaceful Chewy and Jim talking about all that is good in MSK and not rant about the things that are bad. You then said, no, I've got an axe to grind. And you said something about Tier MSK. So that's what we're going to do. I'm intrigued in your thoughts on it. I don't actually know about what your views are on this. So off you go. Tell me about what's up.
Yeah, we'll do. We also have 2 new features. Are you excited about the new features that I'm bringing forth?
I like the names of them. Go on, remind me of
Yeah.
the names of them.
So we've got Would You Rather and Who Are You?
Who Are You sounds ominous. Would You Rather is good. I enjoy those. I hope they don't get like as weird as they might do in the pub. Like that's one of the things that I'm worried about. But yeah, Who Are You
No.
is yeah.
Clean.
I look forward to them. Are we doing them now or at the end?
We can do them now. Would you prefer to do those now?
Oh, go on then. How quick is it?
Go on then. Oh, quick.
Go on then.
Quick. We'll start with Would You Rather, because that's my favorite one. And then if it goes on too long, we'll skip the other one because that one's not. That's just a pun. It's not a really
tantalizing to leave that film next time.
Exactly. Okay. So what I wanted to do was, it's a play on Would You Rather. So would you rather, and this is my question for you. Would you rather have a full week of clinical work where you see new or different patients every 30 minutes? Or would you rather a full clinical week, but you've only got one patient to fill that entire clinical week? And the admin burden is the same, the pay is the same. You've just got to choose between those. You've got a full clinical week of different people at 30 minutes, or you've got one person for a full week.
Do I have to roll the dice on who that patient is or what the case is or whatever if it was the one?
It's a fairly straightforward case. Call it an ankle sprain. There's no real complexity to it.
It's a residential session for a week with that person.
Yeah.
Oh, well, I mean that sounds too bizarre. I've done plenty of weeks that sound like the first bit. It feels like that's lower risk somehow. I get to meet a load of new people. I love to solve problems. I think that sounds more pleasant. I think that it could go really well. The one case ends up being someone that's sound, and you just do a load of rehab with them. It could be so intense and over the top. So no, I'm gonna go for the first one. Yeah. What about you? I mean, it's funny because I want to ask, can you answer the same question? But also, it's hilarious for the listeners that Jim sees like a couple of patients a year now. He's that elite, and so he would just be bowled over by either of those options, and wouldn't know what to do themselves. So if there isn't a third option, which of those would you choose?
Oh, I'd go the many people. I can't be stuck in a room with one person for that period of time.
Yeah, it'd be really interesting. Even if they're the most peacenik person in the world, they would kill you after 3 days. They couldn't stand it. They couldn't stand it. And if they survived till day 4, you'd have to kill them. So yeah, let's not test that water.
They'd be finished off.
Too much murder. Right. What was the next one?
Sure. Right. So Who Are You is you've got to pick 3 people from the MSK world to have dinner with. Who are you picking?
Right. 3 people from the MSK world to have dinner with. And is one of them me? Or can I pick 3 others?
No. 3 other people.
Well, watch them eat.
Can I be there too?
Yeah, thanks. I'm starving. Oh God. I just feel like it'd be fun to just. Well, it'd be. Am I allowed to record it? Is it content?
Sure, you can do what you want. You obviously get their consent first.
with consent. Well, that kind of spoils my idea. Then, if you need consent, yeah. I would have. Is it sort of dead or alive?
Well, like, your choice.
Two ideas. One is you bring back sort of Jeff Maitland, Robin McKenzie. And I mean, Brian Mulligan's still alive, but yeah, let's take those three pioneers of various different. I nearly said manual therapies, but McKenzie, of course, active therapies. But like, yeah, they had I'm sure they had their disagreements, and that'd be fun skirmish. But then if they were alive, if we're going for if they were alive, if we're going for alive on the same theme of like just setting up a decent sort of discussion come fight, then Adam Meakins, Jeremy Lewis, and you've got a referee really awkwardly. You've got to be you, Jeremy, and Adam discussing MSK. Keep it clinical. and you've got to referee that really awkwardly, and and again, it'd be a fun game of like who murders who first, and it'd probably be that they'd both unite in turning on you. I think it could actually be.
Oh, you think that would be the bridge?
That it brings them together. They'd be like, "Wow, actually, we get on really well." You see, this guy is our united
common enemy.
Yeah, exactly. I mean, that's the way that war works, mate. I think that could work well.
Oh, fair enough. Right. Anyway, over with that. So, people can comment or write in or do what they want to do and give us would chew rathers, keep them clean, roughly MSK related, and who are chews would be good.
Okay,
and then
nice
we can discuss those at a later date.
That's painful then.
Or give your answers to those questions would be interesting as well.
No, you've got to give your answer to that last one before I forget.
Oh, the three people. I hadn't really thought about it, I suppose. Well, I caught you off guard, so why do
I had loads of time.
You had. I think I would go for Liz Bailey.
Fun. Yep.
Andrew McCauley.
Yep.
And probably, who would I have in third spot? Ian Gatt.
Oh yeah, and why?
Because I think all three make me laugh and are very intelligent. And I could ask them questions, or we could just chat about whatever.
Yeah, no, that's a nice idea. You got upper limb, lower limb, and conditioning specialists there. And yeah, it'd be just that does sound good. Apart from you'd be there. That sounds brilliant.
Well, obviously, I'd be there in any scenario, ruining whatever social scenario.
That's why you should just pick less important people. I'm now nervous that ever happens, that you just fall out with three of our favourites and then never want to work with us again. So anyway, enough. I've managed to turn every single corner of that into abuse of you, which was impressive. Really, I'm quite proud of myself for that. So yeah, let's get stuck into the meat on the bones of what we're discussing today, which I still don't know what you're on about. Why do you think is it that you think we're in this, or is this a fear, a risk, or is it a problem? What are you on about? 2-tier MSK.
So, okay. I was thinking the other day about, we had this weird, and still have false dichotomy of hands-on versus hands-off. And people still enjoy bringing that up as a debate. Where I see moving forwards a different problem, where a lot of people are what I would call moving towards interventions. So I would include manual therapy, for example, in that, but also things like injections, acupuncture, whatever you want to, things that you do to people. And then I see other people going the other way, or a different way, where it's much more of this health coaching role, dietary, general activity levels, sleep, those kind of interventions, or those kind of ways of managing. And you see these sort of, I see these sort of branching apart of these clinicians who seem to be, they're not, I don't think they're necessarily doing it consciously, but do we think, I suppose my question for you is, do you think that is happening? And then between us, I suppose, do we think that's a problem if that happens? And then so when I was saying about a 2-tier system, I don't necessarily mean one tier being better than another one, but you would eventually, would we go like a bit like we do, I suppose, you see it on our Facebook group on the MSK Hub, people asking for somebody who is very hands-on or somebody who is exercise-based. Do you know what I mean? Are we going to go for, I use the word health coach because I think it's descriptive, or are we going to see, I want somebody who's an interventionalist, rather than, we've talked before about general MSK, where you should be able to do at least most of it and then potentially refer out for specific interventions you can't do, like injections or whatever. I see that happening through the conversations that I see on social media. I am yet to decide whether I think that's a problem. But I think it's sneaking up on people because they're still whinging about hands-on versus hands-off.
I think it's a really interesting point. I don't think it's funny because I don't think I'd spotted it, and also, well, I'd spotted part of it. I think on the interventional front, it was like those, but I almost saw it as being those that were really trying to hark back to diagnostic specificity, and therefore their treatments ended up being really specific. And you see that, and I feel like I've noticed that a bit with this point of care ultrasound journey that I'm on and that we're documenting. And then yes, I think that more rehab active based, especially private clinicians, are then erring towards being in a health coaching role in the recognition of that being sort of someone's trusted advisor. And I think that there are good and bad versions of each of those things. And I think you're quite right. They're rarely nested in the same person because of the nature of the development of the skill set that's required. It takes a particularly committed and impressive clinician to be both of those things and do it well. I think so. Instead, you end up people sort of are subspecializing to some extent. And I think there are, just to give an example of where I think that there maybe are a bit of there's sort of the crap ends of each of those spectrums to my taste is on the interventional side, especially if, let's just say, I've not really thought of it from a sort of manual therapy tape acupuncture type point of view. I think it'd be more interventional being like, here's different flavors of injection that we could do for that niche insertion of your ligament, right? And they're the ones that maybe talking about exactly what dose, what ratio of not ratio is it, the concentration of platelets and plasma in a PRP injection for an insertional traction injury to a ligament or something like that, right? So if you extend it to other interventions in, say, manual therapies, acupuncture, tape, etc., those that are still indulging the hands-off debate, for me, the rubber hits the road in terms of trying to find people that are saying on that is what are you implying those interventions do, right? If you are recognizing that these are valuable interventions that we should keep hold of to some extent, if you are recognizing that they are a mechanism of making transient pain relief for people and sometimes facilitating other active changes in their life or helping someone to comprehend the fact that these symptoms are more malleable than they might have thought, and they're less broken than they are, and you're laying your hands as a means of reassuring touch and all the things that would facilitate good health coaching, right? Then you can recognize that needn't be then a schism, that could be nested, and I'd hope I nest those things within a wider health coaching model, which has been more to my taste because I'm sort of rehab mad. But then if it's taken to that extreme, you've got then people that would be looking for hands-on physio in X area. It's because it's like this person's got really tight trigger points in X muscle that's pulling their biomechanics out, and so we need someone to really aggressively change their fascia in order for them to move better. Right? I'm bored of that, and it just feels like, and it's funny, at each generation it feels like we need to say, oh, here's a podcast we did 12 years ago on that subject matter, and it didn't debunk it completely. I'm not saying it's therefore not worthy of talking about. It's just more that, like, unfortunately, there are some people in the industry that are like a broken clock. They are right twice a day, but what they've done is they're just waiting for 11 o'clock to turn up again, right? So they wait enough time, and then they go, oh, yeah, what about me? What about this thing? I've never changed what I've done, and now it looks like I'm correct again because it's on vogue again, right? And we see that happen, and I've got very little patience for that. But those that are getting too interventional in say, injection sense, I reckon people that are they're overdoing it on the specificity of diagnosis again. I think that they are thinking it's almost like when third Tesla MRIs came in and you could see more things, you then realize, oh, look how much impingement's going on at the hips labrum, because you could see it better. I just feel like that's one of the things that's happening, is that because people are being mistreated with vagueness, they then think that then specificity is then better, or they might do a nerve block, right? It's an interventional nerve block. That doesn't, the fact that that's, as a diagnostic injection, sometimes that can be really helpful. We kind of know that people will know of it at the hip, where you might do a lidocaine injection into a hip joint. And if you're like, is it hip, is it back type vagueness, and it's something that a hip joint injection of lidocaine then resolves symptoms significantly, albeit for a period of time. That's really useful. People are doing that with niche, ever more niche branches of nerve block elsewhere in the body, and then wanting to imply that as the primary issue that therefore needs treating really specifically. It's absolutely, that's bollocks. The logic makes no sense to that, because you've no reason to think that with the right amount of time rehabilitation and other factors that you might be able to then help the body to accommodate whatever is irritating that nerve, if it's non-compressive, for example, if we're not seeing any motor loss. So I kind of get a bit annoyed about that specificity. But equally on the health coaching side, that errs on the side of woo. And also you must get irritated. I'll bring you in on this because it's like the supplementation side of it, isn't it? There's people that often go too far in the health coaching direction. They're sort of supposedly non-interventional, but they're the ones that are saying, right, this particular flavor and style and of omega-3 is going to be the thing that's going to really change you. And they kind of then end up working out a scope at the other side of the more holistic end of the spectrum into wellness and stuff. So that definitely encroaches more in your world on rheumatology, where people start to turn their noses up at steroids and biologics in favor of turmeric, if I'm being cartoonish. But you know, what does that speak to a bit of what you're maybe concerned about?
Yeah, that does happen. I think you could include any of the interventions on that side as well, because you could go with any dietary interventions making a big enough change. Do you know what I mean? So like take let's take a rheumatological condition, ankylosing spondylitis or whatever. Lack of sleep is probably going to be impacting on your condition, and improving your sleep is probably going to improve it, but it's not going to improve it by 90%. Do you know what I mean? So like,
you need turmeric for that.
You need turmeric for that, yeah. So then you go, well, because then it becomes opportunity cost, much similar to what you've described. So if I spend, let's say I see a patient, it seems unlikely, but see a patient and I spend 4 or 5 hours working on them with trying to improve their sleep, is that then worth that amount of time with the improvement that they'll see? Do you know what I mean? So like, it's the same with what you're saying with supplementation, same with diet. You're just not going to make those massive changes. And similar in the MSK world with chronic back pain, for example. You're just not going to see a 50, 60% improvement in symptoms because you've improved someone's diet a little bit. Do you know what I mean? So like, so I think those are interesting points. And I suppose if you take the extremes, then one is not going to necessarily be better than the other, because like you said, you're going to end up with spurious reasoning to get to those extremes. You need to be a little bit more central.
And people don't manage their conflicts of interest well at either end of that extreme either, do they? The
that's
people
what
that are selling the particular flavor of PRP thing that I made an example of, or a favorite colored tape, they can't help themselves but sometimes be cut in on that, or that's what they get. Either on the high end, you end up being cut in on that, or get discount for, or whatever, or you've got a decent markup on those sorts of products. But on the wellness side, we see that with supplements, and we also see it sometimes like physio specialists. Like, we know this as physio matters and as individuals, that if you were willing to shill mattresses and pillows, that is a real useful angle. Like, we could have worked in that direction for a long time. But what they're meaning by that isn't that, of course, sleep and sleep factors we understand to be increasingly important for systemic inflammation and other factors that mean that people can recover better, right? But that, and a physio saying that, you can imagine that being useful for a brand deal, or for someone that's not on the influencer educator side, but that people would be in a position where they might get discounts for their patients for some mattresses and pillows that they suggest, or a type of pillow for neck pain or whatever. There is no way that the evidence-based take on those things as we understand it, which is definitely very relative, and it's more about, you personalizing how much sleep you get, and how comfortable you are, rather than it being, this is good for hips, this is good for backs, you've got left-sided sciatica, this is a sleep position and a pillow combination that you want. That's what the brands want, is they want to imply it's tailored, much like the early Adidas put a treadmill in a shoe shop type bullshit. right? And that's what they want to pay a physio for, is that specificity of which you are then complying with bullshit. Now they don't, often, again, we've said before in this show, haven't we, about being necessarily charlatans that are doing it knowingly, but it's just that then it's that bringing that specificity to bear that you can't defend. That's definitely annoying, and I'd be gutted, because I think sort of a health coaching model and physios being seen in that way, or being someone's trusted provider in the community that's not going to then bullshit them. And also physios, I've got a caseload, as you know, that means that I work on people's functional goals in such a way that then someone who's then recovered from injury or is managing an injury or a health condition, that then want to achieve more with their body, but they then trust you as a physio, having come through that injury journey, that then you are working as a personal trainer come health coach, and you are, it makes sense for people to graduate into that. I think that is so early and so young, and perhaps I need to articulate even publicly a little bit more about how I do that with that, but it will get spoilt quite quickly if that is synonymous with peddling their favorite type of supplement, mattress, pillow, functional medicine, if you've ever heard that phrase. That is a dark web of bullshit as well. When you think those words should go together fairly nicely, and you can imagine that then that'd be useful. Decreased pharmaceutical use and stuff makes sense, it's pleasant, but quite quickly you see people that are advocates for that in the influencer space, and it is a whole heap of over association and just non-valid lines of inquiry. And people always love to suggest that, well, the evidence will catch up. It's like, oh, yeah, we're waiting a while for homeopathy.
Sure. I mean, it is really hard, because I think you have multiple competing factors. We're getting slightly away from the original point now, but you have multiple competing factors.
Weren't that a point there? Let's just deviate. It's fine.
Yeah, just deviate. We have no points.
Actually, that's what we do.
You've got your conflict of interest part that you've just discussed there, and I think one that's sneaking under the radar with that a bit is the shockwave, where people often will charge for a supplement on top, for a variety of reasons, and I don't necessarily have a problem with that, but I think it's an unacknowledged conflict of interest there. Okay. But then also there's this component in the world we live in where gaining attention is very, very difficult, and so if you if you're trying to sell yourself as a insert MSK professional, and your set is similar to yours, really, where you're not providing necessarily a very obvious thing you can gain attention for. So let's take injections. On social media, if you go, I in this area can provide these types of injections, that's quite an easy sell comparative for attention, comparative to what you've just said, which is, I'll work with you over a long period of time to achieve your functional goal. Like, from an attention point of view, they're very different things. And so people, I wonder partly whether some of this split is because of that. So because of trying to gain attention, or, we see it again, strength and conditioning is a really obvious one that I see a lot of people doubling down on, partly because it's attention, but also it's a skill set that they can deliver within a physio and MSK skill set. But it's like we've just said, if you apply that to everything, well, that's not going to be correct either. So it's because people are individuals and they need different skill sets. And this is where, we see some clinics that work incredibly well, but Rob at Dyer Street, our good friend and colleague, Rob Bevan, the multidisciplinary clinics are doing very well because they can have some specific components to them, but also as a clinic provide a more general service where you can cross-refer into your different colleagues. But I just find it a very fascinating divergence that I think we're getting in.
Yeah, I think you've really, the more we've unpacked it, the more I realise how good a spot that is. Really,
I am.
And
I am very interesting. You're right to reflect on that.
Yeah, interesting point. I think that's why I'm surprised by it. It's taken me by surprise. You finally made a good point, and it's bowled me over. What would be a concern is if is if we struggle to differentiate the people that are failing to appropriately reflect on their own conflicts of interest. I think people sometimes will think, for those that might be listening in and thinking, are we thinking just purely about commercial conflicts of interest as if like I'm being paid by a supplement company to peddle their supplements and stuff, right? We can think of that especially as educators, as semi-public people in our space. And those are the obvious ones, right? You know, and we have to make sure we're upfront with you guys when we tell we use and recommend Clinico, and they're a paid partner of ours, and they advertise with us an MSK mag and stuff, and we have to. That's a not really obvious conflict of interest. And if we were shilling a particular flavor of colored tape and we were paid to do so, then you've got to make sure that that's up front. Those are the sorts of things that people realize are really obvious. What Jim's on about, particularly with Shockwave, which is an interesting point, is when if a patient will be paying a supplement like £10-15 extra if in their treatment session they also got Shockwave, then you have this internal conflict of interest as a means of then how do you differentiate or what is motivating you to suggest that to the patient? And then also it's really ambiguous and awkward when people then go, well, I just offer it. It's just on the menu. If they want it, they want it, right? It's not up to a patient to work out how appropriate that is or how much that would enhance their care. The timing of the intervention and how you might feel that might influence the tendinopathy, for example, is a clinical decision of which you can't then say, well, we've got two options here. And then it's just that, well, how deep are their pockets, right? Might as well. Right? It's not going to take any more time. They're going to do it. They're already there. Do they want to just pay that extra bit because they really want to get this better? That is really poor clinical decision making, and so that's a conflict of interest that sort of more like what Jim's on about, which I think is a really fair point, and also one that if your skill set is such that you are sort of feeling like your reasoning means that you've got a suite of a menu of options, and you're just picking through them rather than treating that person's functional needs and goals, whereby those things can sometimes enhance them, then that's a really fair point. And I find it complicating. Very fortunate, of course, to be able to sort of have diversified my career enough that then it just doesn't matter. Like it commercially for Choose Health, it would be obviously helpful if I peddled more injections than I do. Right? I do a steroid injection. I maybe do 2 or 3 a month, but at £400 for 20 minutes, and then I make sure that they sit in the waiting room for 15 minutes afterwards. Right? But it's just so I think we do it as a half an hour session still. But that's high ticket. I've had to develop a skill set for that. I'm not. I think that's a defensible fee. It's still cheaper, I think, than others in the area. But that is such an accessory product because I just don't think that is essential to MSK. And so it's just one of those where we could, the act of not pushing that as a primary service is because I don't want to peddle injections for a living. Like I'd be in a different profession, I'd be paid more to do that, and it's also not central to my ethos and stuff. So it's just a funny one.
But I think this is where injections are almost easier because they're so they're overtly they're high ticket and they are interventional. They have obvious downsides and there are more obvious conflicts of interest there. I think where it becomes really interesting is when your reputation, for want of a better term, is wrapped up in something that is less interventional. So strength and conditioning, for example, or the manual therapies, or dietary, in whatever those other things are, where people will potentially seek out somebody with that skill set because they think that's what they need. Then through conversation, you realize, the opposite might be true. So you see somebody who they want to do strength and conditioning, and you go, oh, well, actually, a steroid injection is the best option for you here. But if they've come to you with that expectation, your marketing is related to that expectation, and then you go, actually, no, there's a very obvious or potential downside where the word of mouth thing that you're reliant on through attention, through social media with that individual, because they then go somewhere else to do the steroid injection, do you know what I mean? Yeah. And I don't know if people necessarily recognize that in their internal reasoning process, where they like it's not necessarily a direct financial impact upon you, but it's this. Oh, well, what is, you're not thinking this out loud in your head, but what is that person? Oh, I went to that person because I wanted to do strength and conditioning in this example, and they said I needed a steroid.
Yeah, well,
the opposite, you would, if being a downside, if I wanted a steroid injection, they told me I needed to go lift weights. This is the same example, just flipped, but you can have one's seen as negative. The other one is negative as well, but I just don't think people necessarily see it in the same way.
Yeah, it's how fairly expectations managed and how shared is the clinical decision making. It's tricky. I think that in these instances, though, it really, really matters what's the context in which the patient has been primed or primed themselves for that. If it's someone that's coming in, you happen to just be around the corner, they'd walk past it, you'd seen it, they'd booked, they'd come to see you, right? You feel like you're as neutral as you can be in a sense at that, for them coming in and saying, my knee hurts, right? Insert thing that you ask them what their hopes, expectations are. They give you fairly general ones. They've not really thought it through in sense of what they want or need. They're just kind of intrigued. Then there's the cases whereby they have done a bit of shopping around, or they've seen other people before. And in that instance, if they've tried lots of different things, but they want to see a more rehab, more conditioning based therapist, the fact that it may well be as part of appropriate shared decision making, you do end up discussing with them injections, surgeries, etc., or scans that might be required or useful, right? Then, but they've partly they've given thought to that before. They understand those things. They understand some of them. You might still have a useful chat about what it does, what steroid does or doesn't do, what the risks and benefits are of that. But they fundamentally are here because, I like you, Jim. Not you, Jim. They don't like you, Jim. They like the Jim.
They do like. Yeah, a lot of people do like me as Jim.
They're like the Jim. That we have, and that they've heard and read about successes there in various different testimonials and reviews, etc. Right? Then there's a position there whereby it's still reasonable, even if you are personally and clinically on the fence about whether or not this would be something that would be smart to have a steroid injection, or there's something that does need investigating, and this might be less of an OA thing, and it might be a more prominent tear of the meniscus or something, and you're therefore thinking that might be more of a classic orthopedic workup that might be smart before you start thinking, can we make symptom modification type strategies in a conditioning format? But if they've come to you in that context, I don't think there's anything unethical necessarily about doing that compared to that sort of said neutral person in the middle. And you're right about differentiating the fact that it's not the intervention or the style of care that makes the difference there. It's the context in which they come and how much then you've got the pre-primed patient. And then you've got to have that composure as a therapist to have the appropriate ethics to then try to come at that as objectively as you can and try to leave as many of your biases as you can at the door. Or at the very least, and this is one of the things I do, is just try to then explain to them your treatment preferences. I had one this morning whereby I'm having to explain, despite the fact that this is someone that admits that they've really found it beneficial when people have done some dry needling in and around their QL and upper buttocks and stuff, and they just find that that's something that they've found to be useful temporarily for various different things. And so you're then explaining that, well, just in terms of where my practice has developed, I don't do that anymore. I trained in it and then moved away from it and found I get better results through other things. And then in this instance, it was that it was a conversation we were having about the fact that they then don't bother about and they don't raise it anymore, in part because couple of manual techniques and a couple of stretches later, and they don't crave that necessarily as they did before. But they also accepted that was something, and we discussed it as being something that you're explaining your own reasoning. You're having the comfort of being able to say, this is how it's evolved. It's not that this is how it's changed. And you sort of trusting the patient to have that conversation, but it's also just having that strength of your own convictions to sort of say, trust that you can justify your own care, including to patients, without it seeming defensive or whatever. You're bringing them along for that, and that is that coaching thing again, which is quite different to you. This is what's interesting about the schism you've implied we might be creating, is that I think that the reason that the coaching done well does just engage on a more human level than something that might be more more biomedical and more interventional in that sense of, right, what am I fixing that's broken? The style of care and the how hands-on or how much tape someone gets through in a typical training week, a working week, I don't think is as good a proxy for it. But it's a fascinating one. I think you've observed something interesting there. I think it's not an easy thing to navigate. And I think that there is also, and where I wondered if you might be going, is that people, I think there is something that we can make sense of there being two-tier system whereby you do need interventionalists where, despite the exhaustion of rehab options, an intervention is required. And it may well be that those are the MSK high-end sports docs and things like that mean that for various reasons, these sorts of things can't be accommodated despite best efforts from rehabilitation. But one of the things that I get frustrated about is where people, I think, are escalated up that pathway far too quickly because there's not quality, competent rehab being done first. And the question remains with this patient that's tried lots of different things, but all of them or some of them naff. They then think that this is the next inevitable stage, and therefore they end up having interventions, and even sometimes successful interventions for things that would have done fine with the right, less interventional care. And that sometimes people that are really interventional can't help but think that that's just a great example of their own success and how silly it would have been to try and do some rehab first because they clearly needed this insert surgery, injection, etc. When actually, no, it's not. We know that that's not the case, and it's got a sort of a misnomer to thinking this over-associate yourself. If you over-associate yourself in the result when you've not got good evidence and certainly no control group next to them, right? Then you've just got to back that off. And you see that when people on the rheumatology side, the fact that I don't know why I'm beating up on turmeric all of a sudden, but I'm just meaning like the fact that people have had great effects from. I stirred some turmeric into my tea for 3 months, and I'm feeling better, right? It's understandable as a patient that they can't help but over-associate the results to the turmeric, when of course there are other factors, including time passing and the cyclical nature of inflammatory symptoms. It is painful, but it's also that humans don't think scientifically. It's not inherent. We don't instinctively do that. People don't reach for that. We've had to train to do that. So you get loads of that in your world, and I think that speaks a bit to this two-tier thing, is that we need people to be interventional, but we also need them to be sane enough to not think that they are magicians.
Yeah, and you see it with literally every intervention you can think of, don't you? And I bet people listening can all think of patients that we've seen do that. They've done the shoulder surgery sham trials where they just, is it enforced rest? Because is it that they've been forced to go through the rehab program? What's the active ingredient in whatever you're prescribing? And you could argue even, like you say with what you do, is the active the attention that the person's getting, and therefore improving. And so it's difficult. And I don't know whether people, it's hard. I find it's hard for me to be unbiased because I've never really been one for interventions. Like I haven't trained in injections or acupuncture or shockwave or any of those things. And so I'm always sitting on the other side of the fence where it's, as another intervention might have done the same outcome.
But that's only for you. It's funny that you say that though, because that's only you administering them. Like you on other levels, like you are as a advanced practitioner of a rheumatology persuasion, you order and advise tests. Even obviously you work within your scope with regards to recommendations on specifics for medications, but you have to have a much more deeper insight into sort of the pharmacodynamics of different drugs and stuff like that. So it's funny because those that you're not the one prescribing them, but you are also sort of recommending and also helping people to manage their own activity levels around different medications and stuff. That means that is quite interventional. So you do have to think in that direction as well.
Sure, but no, but I mean more in I suppose more in an MSK intervention.
Therapy intervention.
Therapies, yeah, however you want to describe them.
Okay.
And it is funny. I find the whole thing, I find the whole environment an odd place at the moment. We've still got, like you say, people arguing very strongly for various acupuncture and, needle types of needling or cupping or lots of different interventions. There's still a lot of that going around, and I don't think that's going away. And should it entirely go away? I don't know. I've softened my stance on that, really. And then you've got other people arguing very strongly for the systemic side of things, where we should be, general activity levels, sleep, reduction of stress, general health, healthy diets, those kind of interventions. And I just find the whole landscape an interesting place as to who is arguing for what and why, and what place each of these interventions lands itself in with regards to the individual person in front of you.
Maybe I'm just getting old, but I just don't find that whenever someone's over advocating for one particular lane of the same road, like I just think that to me looks suspicious. I feel like it just seems, well, it don't mean that people can't subspecialize, but I feel like that's where, for us, we look on and think, well, yeah, that makes sense for them to be really focused on that particular intervention for that particular condition, because that's what they're researching, or that's what their studies have found themselves involved in. Like, people can have their special interests and hobbies, right? Of course they can, but the best people at that also then have the sense to nest that interest and recognize their own nerdiness within the context of the fact that, of course, we just need to sort of help people to functionally scale their abilities, right? And therefore it's part of a thing. It's always just that advocates for particular modalities and stuff, unless they provide evidence that as to why it's being underutilized, I find it really frustrating, or it's something that's not well known. Like, that lad that's doing radiotherapy for benign MSK conditions. Do you remember that guy? He wrote in MSK Mag.
Yeah.
Fantastic, impressive work, right? I don't look on at him and think, well, you're being such a hard advocate for it. It's like, people don't know about it. Even we didn't know about it. Like, this is fascinating, pioneering work that needs to be done, because people would not be considering that for a ganglion cyst. Of course they wouldn't. Like, it sounds mental. Or OA, one of the things that it could be a treatment option, treatment direction, research direction for OA knee is radiotherapy. Like, fair play, you bang that drum. If you're making similar sorts of advocacy noises for shockwave as if it's novel, then you're probably too pro shockwave in some ways, because that seems like you've deluded yourself into thinking it's hyper essential. Similarly, we know it comes in waves, but of course acupuncture is another one whereby people feel like there's just an acupuncture deficit across the nation. Right? If only more people had more acupuncture, especially administered by physiotherapists who can be more specific with the flow of chi in the bodies, then that's going to be a big health intervention. That's where it just feels a bit suspicious. And that's as someone who can get enthusiastic about a whole heap of things, but it's just that, what are you saying? You're saying that instead of something, or you're saying that as well as, are you saying that about, what an impressive breadth of scope we could have in MSK? Let's not stay too tightly in a lane. Like, I really recognize and understand that, especially with some of the work that some of our friends and colleagues have done, where things have swung a bit too hands off at times, including ourselves, and they've made a case for why we don't want to limit ourselves and stuff, and make sure we keep those skills. I like that, because it's recognizing the whole road and all the lanes in that road, and it's recognizing that direction matters more than that. But I'm torturing that analogy now. I can see.
I was going to say, could you talk more about roads? Yeah.
Yeah, and sometimes we just need to lay tarmac in the roads ahead of where it's kind of broken down a little bit. That lane has started to struggle. You know where I'm going.
Make sure it's a dashed line down the middle, not double whites, so you can cross into the different lanes.
Absolutely. Yes, absolutely. Yeah, but then also, recognize that if someone is meandering wildly between lanes without indicating they are mental, dangerous people, that clearly are. Yeah, it works. I think it works. And one of my favorite things to do with these Chewy and Jim episodes is just to end them really abruptly by playing the theme tune.
Chewy and Jim, chatting along on their old pod feed. Chewy and Jim, HR keeps them afloat. We go to play and have a look with Chewy's gags, Jim's dashing looks. The world wishes their views were tame, so Chewy and Jim just take